it's Jadine Paul again, and today we will be learning about prenatal genetic screening and diagnosis. Prior to this session, you've learned about preconception care, the diagnosis of pregnancy, and routine prenatal care. At the end of this session, you will be able to explain the difference between prenatal screening and diagnosis, list commonly used prenatal screening and diagnostic tests, and lastly discuss risk benefits and limitations of available prenatal screenings and diagnostic testing. It's recommended in Canada that all pregnant people, regardless of their age, should be offered screening for the most common aneuploidies. Prenatal screening and diagnosis requires a team-based and patient-centered approach. It should be an informed decision, and healthcare providers must have knowledge of the screen they are recommending. This includes knowledge on risks, benefits, and limitations. It also includes the option of no testing, if that is the decision of the patient after proper review of options. Additionally, the results should be provided in a timely fashion, and there needs to be access for further testing if necessary. Any screening program must also undergo quality assurance and auditing of its accuracy and risks. Prenatal screening programs allow us to screen for the most common chromosomal anomalies which impact pregnancies. We do this as early as the first trimester with an ultrasound, which can measure the thickness of the fluid behind the fetal neck. This is called the nuchal translucency, or the nuchal, just for short. A thick nuchal is associated with aneuploidies. At the same time, at this ultrasound, they also look for the presence of the nasal bone. A smaller or absent nasal bone may be associated with aneuploidy. However, an absent nasal bone is also very common and completely normal for some racialized groups and have nothing to do with aneuploidy. So remember that there are a lot of standard measurements that are often derived from a very narrow, predominantly white population, and therefore may not reflect the normal variations found in individuals of diverse genetic ancestry. These ultrasound findings, however, meaning the nasal bone and the nuchal translucency, in isolation are poor screens due to low specificity and sensitivity, which is why we combine these tests, this ultrasound, with a serum marker that is done either in the first or second trimesters. The combination of the ultrasound and the serum markers depends on the provincial screening program. If done in the first trimester, the free beta HCG, the PAP-A are done. And if the screening is done in the second trimester, like in some other provinces, an AFP, unconjugated estriol, HCG, and inhibin A are done. In Calgary, we are lucky to have the first trimester screen, which combines the person's oocyte age, the nuchal translucency measurements from the ultrasound, as well as the free beta HCG and the PAP-A. Wherever you end up practicing, you should be aware of what is offered in your province and area. Age of the pregnant person is used as part of screening because the chance of pregnancy is affected with a chromosomal abnormality increases with oocyte age. You can see here that there is a relationship. As the age increases, so does the risk of chromosomal abnormalities. The use of cell-free DNA has changed prenatal screening for aneuploidies. Cell-free DNA, if you've never heard of it, is a blood test that's based on the premise that there are maternal and fetal cell-free DNA in the pregnant person's circulation. This allows us to screen for possible fetal genetic conditions through a simple blood test of the pregnant person. Cell-free fetal DNA can be detected as early as 7 to 8 weeks pregnancy, and most companies will do it by 10 weeks. There are a lot of interchangeable names. You might see cfDNA or CFF DNA, which refers to cell-free fetal DNA, or NIPS, which refers to non-invasive prenatal screening, and they all refer to the same type of test. At this time, NIPS is used to screen for the most common aneuploidies, which are trisomies 21, 18, and 13, and some X-linked disorders. In some other countries, such as the UK, it is used to determine fetal RH to base the administration of RH immunoglobulin in pregnancy. In some instances, it can also be used to screen for certain disorders that a patient is at risk for. So, for example, certain known deletions like Q2211 that we'll mention in a little bit. NIPS is more accurate than a nuchal translucency or serum screens, but at this time is not covered by provincial health care. Prenatal management should not be based on NIPS alone, which means that if the NIPS test returns as high risk for an aneuploidy, then it is still recommended that the patient proceed to an invasive diagnostic test to confirm. A congenital anomaly refers to an anatomic structural anomaly present at birth. These defects can be caused by genetic abnormalities, environmental exposures, and or infections, although a lot of times the underlying etiology is not known. TORCH refers to toxoplasmosis, others being syphilis and varicella, rubella, CMV, and HSV infections. Congenital anomalies can be either isolated, being seen alone, or present in a combination or pattern that may affect one or more organ systems. Remember that I mentioned that 2 to 3% of all healthy live babies are born with a congenital structural anomaly with no identifiable cause. All pregnant people should be offered a routine second trimester screening ultrasound between 18 and 22 weeks. At this ultrasound, the fetus is examined from head to toes, counting every single digit and looks at every single organ. This is also the ultrasound that confirms the location of the placenta, which you'll learn is important from a prenatal and intrapartum perspective. Congenital anomalies are the leading cause of infant mortality and morbidity, with the most common being cardiac, neural tube defects, and cleft lip and palate. Remember that screening is applicable to a population. Diagnosis is applied to the individual patient level. Screens are used to determine who is at increased chance and are reassuring for most of the population, and it is non-invasive. Those that have a higher chance based on the screen are then offered diagnostic testing to definitively identify the etiology. The diagnostic tests are more invasive and are associated with a little bit more risk. Prenatal diagnostic testing includes 2 invasive procedures. The first is chorionic villus sampling, which is done between 11 and 14 weeks, and this is very accurate, but has a miscarriage risk of about 1%. The second option is called amniocentesis, which can be done around 15 to 22 weeks or more, and this is considered the gold standard for prenatal genetic testing. It is also very highly accurate and has a slightly less risk of miscarriage. Both have a small risk of bleeding and infection and rupture of membranes. These procedures are done by our maternal fetal medicine colleagues. Patients who are considered for these procedures are also seen by our medical genetics colleagues as part of informed decision making prior to proceeding to these tests. With the sample that they obtain from the CVS or the amnio, they can then perform genetic testing. Depending on the suspected etiology, different tests can be done on the sample. These include rapid aneuploidy detection of the most common aneuploidies I've mentioned, which again are trisomy 21, 18, and 13. Deletion syndromes like 22q11 can be tested by a directed array because you know what you're looking for. Other things that you might be looking for would be suspected single gene conditions, and these are tested again on specific arrays that look for specific genetic abnormalities or can even sequence specific genes. Decisions for these tests are done by our specialist genetics colleagues, and I think at your level and even at my level, we just should have an idea that these tests exist, and I think further details is really beyond our scope. When patients are offered the screen or diagnostic test, benefits and risks must be considered. Benefits include providing reassurance to the family and reproductive choice to the patient. These tests also allow for early detection and intervention if they so choose. If the tests are positive, they allow for the family and the healthcare team to be prepared to better care for the pregnancy and the developing baby. Risks include the fact that, these are not perfect tests, and there is also a risk of fetal loss. Making the decision to pursue testing can potentially cause a range of emotions for the patient and their family, from distress, maybe anger, guilt, anxiety, and all this can contribute to tension in relationships and the family as well. And maybe just start to think, why reassurance is important to some people and not for others, and how it might reflect ableism. Here is a really great summary slide of the different screens and diagnostic tests and when they are usually done in pregnancy. So thanks for listening. The next time we will meet to continue the prenatal care journey will be in block 272. We're going to learn how to help somebody become pregnant and also how to help somebody if they do not want to be pregnant. Then I'll see you again in 273 and 274 for all of prenatal care.